We talked about reasoning, clinical reasoning methods. Remembering that clinical reasoning is a subset of critical reasoning. That's using logic and evidence in your deductions. And the methods we came up with were differential diagnosis, both positive and negative, hypothetic abduction, or possibly hypothetic inference, probably whichever one you want, script focus, hypothetic abduction or inference, and pattern recognition. These are the ones you should be using for the most part. Now, hypothetic abduction, previously called by me hypothetic deduction, which is wrong, is usable. The problem is it's not used correctly. You should be making a hypothesis and then prove it or disprove it with more evidence, more information. Most people don't do that. They think hypothetic deduction is simply throwing as many questions and tests at the patient you possibly can, and then trying to deduce or infer what's coming out the other end. That way leads to anchoring, confirmation bias, and all sorts of messes, and it gives you a headache. So that's really not the one to use. Script focus hypothetic abduction is probably the best way to go here. Use the minimum amount of information you need to make the diagnosis, not the maximum. This will reduce bias and make life a whole lot easier for you, and allow you to switch hypothesis pretty quickly when it's not working out for you. The other one is pattern recognition, which isn't teachable. You have to gain that by reflective practice and honing logical skills. But eventually you'll learn these patterns and you'll be able to come up with a couple of differential diagnoses automatically, and you will also automatically compare the differentials with your pattern recognition diagnosis. So those are the main methods we used. As far as conditions are concerned, I believe these were the only ones we really talked about. Disc herniations, prolapses, extrusions, sequestrations, internal derangements, or often called contained herniations, where there's no bulging of the disc, but the nucleus migrates between the annular layers, and when it reaches the nociceptive part of the annulus, it can produce pain. Stenosis, both central and lateral, spondylolisthesis, healthy and pathological fractures, stress fractures, arthropathy. You will get information on all this, and you probably already have that information in some of the videos. So I'll give you the high points of this. Disc herniation, the prolapse and extrusions usually come with a radiculopathy, not always, but usually do. There's severe back pain, leg pain, a deformity, a rotoscoliosis, ankyphosis, functional impairments in all directions, sitting, walking, standing, and the range of motion is limited in all directions, and all are very painful. The straight leg raise is positive with these, whether there's a radiculopathy or not. The dura will give you the straight leg raise. Biomechanical dysfunction, the average presentation is episodic, short duration, week or 2 weeks usually, and then a long period between that and the next episode where it's pain-free, you're at full function, and then it comes back again. And these tend to get worse if they're not handled properly. So the episodes start to last longer, the episodes get closer together, and the pain becomes more intense and the disability becomes more problematic, until eventually this can actually just stop being episodic and just be continuous. So it's an episodic short duration pain, flexion or extension impairment, or at least it's dominated by flexion or extension. The range of motion is limited in one direction, either extension or flexion, along with its associated movements. The pain is moderate, occasionally severe when you do something wrong. I think that's about it. Stenosis, age is a factor here, almost always. These people tend to be over 60. Central stenosis tend to be a little bit older than lateral stenosis, and central stenosis tends to affect the whole region, the whole lumbar spine, if you like, whereas lateral stenosis can affect just one segment. We're talking about structural stuff, not the disc producing a stenotic canal. This is structural. So it's a degenerative condition generally. And basically extension's a problem. They can't stand for too long, they can't walk too far or too fast. The symptoms are bilateral, central, unilateral with lateral stenosis, and there may or may not be a radiculopathy. Spondylolisthesis is stenosis. That's a form of central stenosis. It does close the canal down, so it looks exactly the same, often though more severe. The age is also different. This tends to be either in adolescence or in middle age. So one's surgical and the other one is sort of degenerative type. Healthy and pathological fractures are similar in that they have a sudden onset of severe pain at the time or within an hour or so of the trauma, whereas stress fractures, it gradually worsens and worsens and worsens. Their function cuts down, and there may be some pathological in this as well in the form of osteoporosis, where the stress, which wouldn't normally damage the bone, does. So it may be a combined stress pathological fracture, but the picture of it is as a stress fracture. And then arthropathies, traumatic arthropathies, microtraumatic arthropathies, systemic. These can be a single segment, but more likely they're going to be systematic. The SI joints, lumbar spine, and so on. We then looked at biomechanics, both the biomechanical dysfunction and the biomechanical exam, and we basically started the examination using position tests. I think this is the best way to go, I really do. It's much easier than doing the legs backwards and forwards and so on. And we'll go over that with you, make it a bit easier for you. But I'd use position tests every time. So what we did was we had the patient flex forward, so they could either do it in sitting where they just put their hands on the floor, or they could go onto elbows and knees and curl up. So for flexion, the most hit posterior transverse process is the one that's least mobile, either because it's actually hypomobile or because the other one is hypermobile. So your first hypothesis is hypomobility. It's the easiest one to pick up. And as I say, the hypomobility will be ipsilateral to the posterior transverse process. You're going to have to apply some pressure here because you've got to work your way through the muscle usually, but not enough to move the vertebra. If that turns out to be negative, the second hypothesis is hypermobility, which is contralateral to the posterior transverse process. And then if that's okay as well, you don't have a movement dysfunction. So H3 is that it's compensatory. Now, remember, this is a screening test. These are not 100% at all, but you can be reasonably sure that if outside of a severely painful back, which can basically splint the vertebra where you want it, this will show up what you need to look at further. Extension, you prop them up on the elbow. The least mobile now is the one contralateral to the posterior transverse process, as the mobile one comes further back. H1 is hypomobility, contralateral posterior transverse process. H2 is hypermobility, ipsilateral to the transverse process. H3 is no movement dysfunction and it's compensatory. From here, we moved on to the P-PIVM. In flexion and extension, a PA is your P-PIVM. So you have them in flex, you push on the posterior transverse process, this will try to rotate the vertebra in the flex position. If it can do that, then you don't have a flexion problem. Usually it can't, you get an abnormal when fill. That tells you that that side, the right side of the vertebra, is hypomobile. You then do the PAVM, which will tell you whether it's the joint or whether it's an extra-articular problem. We'll come to that in a second. For extension now, you still push on the posterior transverse process, rotating it to the other side. And this time though, if the left facet can glide downwards, then you don't have a movement dysfunction. If it can't, then you'll get that jammed end fill underneath the posterior transverse process. So in both cases, if the P-PIVM's negative, you then check to see if you have a hypermobility on the side, and that means trying to slide the right side, the ipsilateral side, you're just pushing on further down. And you can do that by actually coming on top of the transverse process and pushing it downwards, or you can come underneath it and push the one below it up. They're probably the two best ways to do it. Not as easy to fill. If the P-PIVM is restricted, then you move to the PAVM, which is done in flexion extension on the posterior transverse process again, but now instead of pushing it anteriorly, as you did the P-PIVM, it's pushed supro anteriorly. If you're wondering why supro anteriorly, because it's more than supro anteriorly. It's a more superior push, a little less of an anterior one. So that's the biomechanical assessment here. Not including segmental instability, which I'm really not going to cover too much with you. What about the biomechanical diagnosis? There are really three states we have to worry about: hypermobility, instability, and hypomobility. As far as hypermobility, we talked about irritable versus non-irritable, or if you prefer, painful versus non-painful. Irritable hypermobility, you'll have full range of motion. When you overpress at the end of the full range, you'll have spasm kicking back at you. This is telling you that this is protective. It's stopping the joint from moving further. And if you've gone full range, the only way it can move further is if it's hypermobility. So you infer the hypermobility from the presence of end range spasm. Non-irritable hypermobility, you'll be able to push it into that hypermobile range and pick up the abnormal end fill. When you're looking at spinal joints where there isn't much movement, trying to decide if there's 1 degree of movement too much is actually ridiculous. You have to rely on the end fill. Instability, basically these are movements that exist that should not exist. And for us, probably the most common one is that the translation is increased. The muscles of the segment are designed, the local stabilizing muscles are designed to control translation. You need translation, but you don't need too much of it. So these things will limit that translation. For most parts, segmental instability is where that translation isn't being controlled either by the muscle or by the inert structures that's supposed to be doing it. If you have a subluxation, you can guarantee you have an instability, because I don't think it's possible to have a subluxation without an unstable segment. And then we've got hypomobile pericapsia, which is due to the capsule or joint ligaments being incompetent, basically, either attenuated or torn, in either case not doing their job. And then you have a pathomechanical or sublux joint, where basically it comes off its rails and it jams at one end of the range or another, and you lose the entirety of one movement. And when you move into the subluxation, you'll get a relatively normal end fill. The quality is going to be normal. The quantity may not be. This may be hyper soft capsular when it should be a harder capsular end fill because you've been stressing it. So it's all about end fill. You try and take it out of the subluxation and you're going to feel it jam. You try and take it in and it's going to feel relatively normal, although there won't be much movement there because it's already there. We then looked at the cervical diagnostic exam. Same with the lumbar spine, only use the tests that will challenge your hypothesis. Keep these exams as minimum as possible. You're going to do bias checks with more differential diagnosis, so you'll do a bigger exam as you go through the whole total examination, because you want to know about their work, their social life, activity, and so on. But don't do them when you're trying to make the diagnosis. You're getting too much information to really do that happily. So only those tests, which includes questions that will challenge your hypothesis. I'll give you an example here of right suboccipital pain. H1 may be biomechanical dysfunction. Question, the history of short duration episodic pain, severity, moderate severity, mostly moderate. What can't you do? And we're looking at non-obligate functional losses here, with one direction dominated, range of motion being a loss of flexion or extension, PA's appropriate pain and infill. If you got all that, you can then look at your differentials, which may be fracture, torn ligament, so on, and then compare them with your hypothesis. Then we looked at cervical anatomy and disc degeneration, and I talked about the formation of the Uncinate process occurring in the first 10-12 years of life, and from that the U-joint develops as well as the Uncinate process articulates with a facet on the vertebra superior to it. It gets covered over with capsular material and fills up with interstitial fluid, and that's your joint. It's not a synovial joint. And the cartilage is fibrocartilage, and it's rough and hard. It's a disc, basically. The disc splits and becomes the joint surface. So this one is almost designed to sublux and jam up. The disc loses its nucleus. By the time you're 30, it's pretty much gone at every level except the lowest. And then you get splitting across the disc in the back half of it from side to side, and it moves back through the disc. And again, this is completed by about 30 years of age. Degeneration and degradation result in disc height loss. Conditions: biomechanical dysfunction, pretty much the same as lumbar dysfunction. Traumatic and systemic arthritis, fractures, ligament tears, intracranial bleeds. Disc herniations, which are really not disc herniations, but externalization of that discal material. Not common, and certainly rare above C5 or 4. So those were the conditions I think we looked at. Okay, so let's have a look at the biomechanical exam of the neck. The PPIVM was side flexion, translation, inflection, and extension. Neutrals a bit insignificant and trivial. You really don't have to worry about that too much. So in extension and left side flexion, if that's restricted, the problem is on the ipsilateral side of the segment to the side flexion. So if I'm side flexing left and translating right, then if the facet cannot reach its full extension. The reason it can't reach its full extension may not be the facet. It may be an extra-articular problem that's stopping the facet from getting there, or the U-joint that's not getting there. But for the moment, we're going to say it's whatever's stopping the segment is stopping the facet from reaching full extension. So the PAVM for that would be the supro-inferior glides and the zygapophyseal joint and of the U-joint, which are inferior and superior glides. Inferior for the ipsilateral side and superior glide for the contralateral side. So if this was an extension loss and left side flexion, we'll say it's at L3-4, then we'll check the inferior glide of the left L3-4 facet joint, the inferior glide of the left unconvertible joint at L3-4, and the superior glide of the contralateral U-joint of L3-4 again. If it was a flexion problem, so we'll say flexion and left side bend is restricted at L3-4, we'll check the superior glide of the contralateral facet, that is the right facet, and the inferior glide of the ipsilateral U-joint, that is ipsilateral to the side flexion, and the superior glide of the contralateral U-joint, contralateral to the side flexion again. The diagnosis we can make from this is the same as it was for the lumbar spine: hypermobility, irritable and non-irritable, instability, surgical instability such as sharp Purser test with an AA instability, an alar ligament instability. These are ligamentous instabilities, posterior longitudinal ligaments, and so on. In the spine, you get the same thing. If the long ligaments are torn, these are more not so much biomechanical instabilities, but surgical, for want of a better term. Or we can have hypermobility, extra-articular or articular. Articular being pericapsular and pathomechanical or subluxation. flexion or extension, subluxation of the facet joint, or a superior and inferior facet, subluxation of the unconvertible joints. Simple as that. And finally, the other major topic we talked about was the sacroiliac joint, the anatomy, and the movements and the labeling of those movements. So the anatomy, we said that basically this joint needs to be very, very stable. It's got to support your entire trunk and head weight, and also support that when there's impact forces coming up from the ground. So this has to be a very stable joint, but it also has to have some degree of mobility, not just for pregnancy, but for normal biomechanical motions. So if we look at stability, you'll find first off that the two surfaces are really co-equal. They're about the same surface area. Now, whenever you see that in a joint, the amount of motion that's allowed at that joint is restricted. The more equal they are, the less movement there is available. On top of that, then you have the primary contour, which is that bilimbic sort of banana shape. And that's going to limit gliding. You can't travel down two tracks that are not parallel, not for any distance anyway. There's also the secondary contour with the furrow and the ridge in the center of this that tend to interlock. Not perfectly interlock, but they tend to interlock. And then you have horizontal ridges running across the joint surfaces that's also going to stabilize it. There's huge ligaments here, very strong, particularly the interosseous ligaments, short and thick and powerful. The posterior ligaments in this joint are also strong. Ventral ligaments, still strong, but not the strongest of the bunch. If anything's going to tear, it's going to be that one. So this is all about stability. Mobility side, probably the reason why it's got any mobility at all is simply because one of these surfaces is deformable fibrocartilage. And if you put weight through it, you squeeze the surfaces together and you can deform the fibrocartilage with body weight. So this is how you get the mobility that you do. As we talked about in degeneration, the mobility decreases because the articular surfaces, the hyaline gets thinner, but the ridges, the contours get more emphasized. They become deeper and fatter, so the stability increases, but at the same time it can grip onto the fibrocartilage better and still move it. So even in age, it never stops being mobile. Even in extreme age, it's still mobile outside of it fusing in pathology. Then we talked about the movements it's got. Well, it can rotate anteriorly, rotate posteriorly, it can laterally rotate, it can medially rotate, and there's probably some degree of ab and adduction. So it probably can do all of the same movements everything else done, but to a much lesser extent. Now, anterior, what I said to you was this. Flexion is a movement towards the fetal position and extension away from the fetal position. So anterior rotation of the sacrum is really quite simple. This is a spinal bone. Spinal bones anteriorly rotate and they flex. Sacrum is no different. If you start looking at lordosing though, you're going to look at the lumbosacral junction. That's extended. When the sacrum is flexing under 5, you'll get an extension of that segment, but that's not the sacrum. The sacrum is flexing. If it rotates posteriorly, basically it's extended. The innominate, though, is a little different. Anterior rotation, although you might think of it as extension, isn't. You might think of it as flexion, it isn't. It's extension. If I bend my knees up to my chest, the innominate posteriorly rotates, and that's a fetal position. So the movement away from it is extension. Inflaring, the osteopathic term for it, is medial rotation, and outflaring is lateral rotation. So that's the movements it can do. As far as labeling is concerned, the problem here is that the two bones are side to side. So the spinal convention where the superior bone is the reference point, and the peripheral bone, and in the periphery, it's the inferior bone that's the reference. Doesn't work here. They're side by side. Also, the sacrum is a vertebral bone, the innominate is a peripheral bone, so that doesn't work neither. But it's not difficult. Sacral flexion with the anterior rotation of the sacrum means that, relatively speaking, even if it doesn't move, the innominate is posteriorly rotating. So flexion of the sacrum is flexion of the innominate. As far as the joint's concerned, it is flexing. And the same type of idea for extension. So the way the joint move, the way the bones move, actually name the joint movement. So it's not as difficult as it might seem. Okay, I think that's where we got to. Good luck. I'll see you in a couple of weeks. Bye.